Hello, this is Michelle from Physioactive Indonesia, bringing to you our Singapore Surgeon Insight series. Today, joining us is Dr. Andy Wee, Senior Consultant and Orthopedic Surgeon from Pinnacle Orthopedic Group, Singapore. How are you, Doctor?
I'm good. Thanks for inviting me, Michelle.
Thank you for taking the time to be with us. Doctor, can you please start by telling us about your qualifications and specialities?
Okay, all right. So I'm an orthopedic surgeon practicing in Mount Elizabeth Hospital in Singapore. I've been in practice for the last 13 years as an orthopedic surgeon. And actually, my main qualification and subspecialty training is in two areas. So first of all, I subspecialize in shoulder and elbow surgery, and I underwent formal fellowship training at the Mayo Clinic in United States in 2010. Um, Specifically, I'm also fellowship trained in arthroscopic surgery and sports-related surgery, and I did a second formal fellowship at the Fowler Kennedy Sports Medicine Clinic in Canada. So actually, I have two areas of subspecialty training. Prior to me moving out into private practice in 2016, I was actually the head of department for one of the public hospitals in Singapore. I'm also an ex-national athlete. I play squash for my nation in my younger days, and that has helped me in my practice in treating athletes. I find that I'm able to understand their needs and their desires to return to the highest level of sports. Last of all, I'm actually a visiting consultant to many of the public hospitals to offer my specialty expertise in helping the government hospitals treat many of the complex pathologies that they face. Thank you.
Wow, that's quite a bit of accomplishments, Doctor.
Thank you.
Yeah. So let's get into our topic for today. We want to actually, or
Yes.
we have a lot of patients that have a lot of questions on shoulder issues. Let's start off by asking you what are the common shoulder problems or complaints that patients see you for?
Okay, so typically when patients come and see me, they complain of a few things. One of the commonest complaint would be shoulder pain. All right, that's probably at least 50% of the shoulder complaints that I see. Secondly, they complain of stiffness. And sometimes, of course, pain and stiffness can coexist. The third complaints that they have is weakness, where they feel a lack of strength in maybe elevating their arm. And then the last of all would be instability, where they feel their shoulder shifting out of the joint or actually dislocating out of the joint. So these are the four common problems that I see in shoulder complaints.
Okay, and do the patients that come in with these complaints, are they usually the younger ones or the old ones in age?
Yeah, that's a good question. So the younger patients typically present with instability. I mean, of course, they can have pain, but that's usually due to a trauma that they develop pain. But interestingly, the younger patients, as we are younger, we tend to have our joints are looser. So they tend to have problems with instability. So they may come and see me saying that this shoulder has dislocated a few times or their shoulder has shifted. And of course, this can be associated with pain. The older patients usually don't have problems with instability. They typically present with pain. They tell you they have stiffness. And of course, if this is long-standing, then these symptoms can result in weakness as well.
What is usually the diagnosis from such pain, instability, or stiffness?
Yeah, so in the younger patients, typically they would have an episode of a dislocation, typically, right? And then they will tell me that their shoulder dislocates again and again and again. And that's typically due to a torn labrum, which is the bumper around the shoulder socket. And that results in the shoulder being unstable and they have symptoms of recurrent instability. The older patients typically presents with pain and stiffness, and the two commonest diagnoses that I see in my practice would be number one, frozen shoulder, and number two, rotator cuff problems. Frozen shoulder, it's a very common term that people use, but essentially the pathology is actually in the joint capsule or the inner lining of the shoulder joint. And it's actually quite common, and many older patients have no preceding injury or trauma that precipitates this pain and stiffness. So frozen shoulder is typically a more benign condition, and it can arise without any injury. It has an insidious onset, and the patient noticed that they started developing pain, which oftentimes is accompanied with stiffness. But frozen shoulder is typically a benign and self-limiting condition. Interestingly, it tends to resolve with time over a period of 6 to 9 months. Of course, in a small select group, that doesn't happen, but the majority of the patients will go through that painful phase and then that frozen phase, and everything starts to improve. And of course, it is important to differentiate frozen shoulder from rotator cuff problems, because frozen shoulder typically takes a benign course. And I typically would recommend them a simple steroid injection that is directed specifically into the shoulder joint. And that typically brings down that inflammation of the joint capsule. And subsequently, I think what they would need most would be physiotherapy to help them regain their range of motion. And that typically helps in most patients with frozen shoulder.
Okay, doctor, let's elaborate a bit on this injection that you give for frozen shoulder.
Yes.
Is it something they only have to take one time, or do they have to take several times? And what does it contain? Can we get more details on this, please?
Yeah, that's an important point to discuss, Michelle, because if you read in the internet or you see in the internet, you can be fooled and say that steroid injections are dangerous. Steroids have gotten a bad name, but actually for the wrong reasons, because most of the side effects from steroids are from repeated injections. And I'm glad you brought this up, because when we use steroid injections for frozen shoulder, we give it into a very specific location, right into the shoulder joint, not to the subacromial space. And it's a one-time injection. So I give the injection once, and if it doesn't work, I would not recommend repeating the injection. Then we have to start wondering, is there something else that's troubling the shoulder on top of the frozen shoulder? So typically patients, given the right injection, patients would respond in two ways. Some would tell me that their pain has improved significantly and their range of motion just comes back. Okay, and that's the happy patient. Some patients with frozen shoulder, unfortunately, do not get such a dramatic response, but they also tell me that their pain has improved, but maybe the stiffness has not improved. And the reason is because that frozen shoulder has been a little bit long-standing, so the scarring has already formed. But still, with the injection reducing the pain, they feel a lot better. And like I said, I typically recommend that they see a physiotherapist, and you should expect that range of motion to slowly improve together with the pain relief from the injection.
Okay, let's talk about rotator cuff problem then, doctor.
Yes, so rotator cuff problems are typically something that patients are less aware of. So most of the patients who come and see me with pain and stiffness over the age of 50 will tell me, Dr. Wee, I have frozen shoulder. So they make a diagnosis of their own. And I would say that yes, many of them have frozen shoulder, but actually maybe about a third of them have something more than something other than a frozen shoulder, and typically it's a rotator cuff. Okay, and a rotator cuff essentially are a set of 4 muscles that envelopes the shoulder joint. Okay, and they are important for movements, coordinated movements of the shoulder, and they also provide some stability. And the rotator cuff can feel very much like a car tire, and typically that's why patients present with rotator cuff problems as they reach middle age, 40 and 50. That's not to say that younger patients can't have rotator cuff problems, but when a younger patient presents with a rotator cuff tear or inflammation, it is usually due to a significant injury that is sustained. Whereas in the older group of patients, they typically present quite insidiously, or maybe they have a minor trauma. So it's important for us to tell the difference, because like I said, frozen shoulder, we treat them typically non-operatively with injections, with physiotherapy, and we expect them to improve. Okay, whereas rotator cuff problems will depend on the severity of the disease. Is it an inflammation of the tendon, or is it a significant tear, or is it a very large tear that can typically retract? And if the large tear is undetected, it can retract and cause weakness. And if we detect it very late, of course, repairing it becomes more difficult as well.
So, what are the steps in the assessment you take to make these diagnoses?
Yes, so I think that's the diagnosis is key. So many patients come and see, what's the treatment? I say the diagnosis is key because the diagnosis will lead us to the right treatment. So typically they'll present with pain and stiffness, right? That middle-aged patient. And I would say that the first thing we do in our clinic is to examine them. And actually, this is quite an easy way to tell the difference because the frozen shoulder would have stiffness of the shoulder that is not correctable passively, meaning I can't move the shoulder up as well. So it's not a lack of effort or due to weakness, but an absolute loss of range of motion. And frozen shoulder tends to have limited range of motion in every plane of movement of the shoulder. Whereas a patient with a rotator cuff tear, they may have difficulty lifting their shoulder in certain directions. But if I examine the patients, I would be able to passively lift up their shoulder without them having much difficulty. So I think that's the main distinction. But of course, during that assessment with the patient, besides that clinical examination that we conduct, typically I would recommend two investigations. One is an X-ray that looks at the bone quality, and that can be done very, very quickly in our clinic. And it tells us the general condition of the shoulder. Is there arthritis setting in? Is the joint generally healthy? And typically in a patient with frozen shoulder, we would expect the shoulder to be normal, okay? The X-ray to be normal. And that leads us on to the second investigation, which is an MRI scan. There's of course a pain-free scan with no radiation involved that typically gets done on the same day when we assess the patient. And the MRI scan can confirm the integrity and the status of that rotator cuff muscle or tendon.
Okay, so depending on the severity of the rotator cuff problem that the patient
Yes.
has, what are the treatment options that are available,
Yes.
doctor?
Yes. So typically, I would say 80 to 90% of the patients who see me with a rotator cuff problem will either have a rotator cuff strain, which is something that they can develop because of an unaccustomed activity, some degree of rotator cuff inflammation, or maybe a very small partial thickness tear that can develop not because of any specific trauma, but just from putting more candles on their birthday cake every year, So for most of these patients, up to 80-90% of them, the treatment is a very benign conservative approach. So I would tell them, rest the shoulder, modify the activities, avoid overhead activities, avoid repetitive usage of the arm. You can see a physiotherapist, which typically helps, and I would explain to them that physiotherapy will not improve the shoulder condition after one session. I would typically expect improvement after maybe 6 to 8 sessions. And I would also give them some anti-inflammatory medicines that they can take to relieve the pain. And last of all, like we speak about, an injection, like a steroid injection, can also help conditions that involves the rotator cuff. So that's the typical recommendations for what I think is 80-90% of the patients that I see.
And at what point is surgery needed then?
Okay, so typically surgery is needed. The commonest reason is for failure of non-operative treatment. So it's someone that I've done all this, I've sent them to a physio, they've tried all these medicines, and they don't improve. That's where surgery would come in. But there are certain groups of patients where we think that surgery should be probably something that we consider fairly early. So like we mentioned before, if it's a young patient that had a significant fall and the rotator cuff is completely torn, that is very clear in the literature that these patients do better with early surgery to repair that tendon, because these are young active patients, their tendon quality is healthy, the tendon would want to heal, so we want to repair that tendon almost early so that we can get the best outcome for them. So if it's a young traumatic tear, we tend to recommend early surgery. If it's a tear that has already been going on for a long time, it's chronic, it's large in size, and it's retracted, we are a little bit worried as well, because those are the tears that can be even more difficult for us to repair by the time we wait another 3 to 6 months of conservative treatment. So in those situations, again, we would recommend early surgery. And of course, the last group of patients that sometimes we need to perform surgery is when they present so late, where you have a very bad tear that has developed into an arthritic shoulder joint. In that group of patients, of course, again, surgery would be the most predictable outcome. But in general, like I said, I would still say a ballpark figure of 80 to 90% of patients would generally be recommended a trial of a non-operative treatment first. Maybe 10 to 20% of my patients would require surgery either because of a failure of conservative treatment or because it's a pathology that would be better served with surgery.
And what does the surgery entail? And can you tell us about the latest advancements in rotator cuff surgery, please?
Okay, so surgery, the good thing about surgery is, when patients say, oh, I need surgery, and they get worried, but the honest truth is, for that 10 to 20% that requires surgery, interestingly, the 90% of this small little group of patients would require only an arthroscopy. All right, and of course it is a surgery, but it is still done under general anesthesia, but it is done through small keyhole incisions. So typically 3 to 4 small little holes that will allow a small arthroscopic instrument to get in. An arthroscopic instrument is like half the width of a pen that you use. So small little keyhole incisions. It is typically a day surgery. It is typically something that patients get admitted on the day of the surgery. It takes us about 2 hours. And typically patients go home the very next day. So it is a minimally invasive surgery. And patients recover quickly from this surgery, all right? And during the surgery, what do we achieve, all right? So we put a scope in, we can evaluate the tear, we can see the tear very well. We use arthroscopic instruments, and basically we repair the tear. On top of that, we tend to remove any bone spur. It's almost like sending your car for servicing, besides changing your car tires, we give the car a good vacuum and a good wash after the entire servicing. So the same thing for rotator cuff surgery. So fairly minimally invasive, low morbidity, quick recovery surgery.
And two questions for our Indonesian patients specifically
Yes.
what should their travel plans be like when they want to do a surgery? In a sense that do they
Okay.
come in for the surgery, as you said, and it's a day thing and they can travel back home, or do they need to stay back for several days for a post assessment with you? And the second question is, if they decide to delay the surgery,
Yes.
what are the
Yes.
consequences?
Yeah. So I think I would recommend now with us having a lot of online consultations. So the simplest way for the Indonesian patients would be, I think, to drop us an email or maybe even organize a Zoom consult with us, which our clinic provides. And during that consult or even that email conversation, we can look through their scans, which many of the patients have, run through some of their symptoms. And of course, if they have no scans done, then of course they can fly down to Singapore and get a scan on the same day that we consult them. So I think that's the first thing that we do. And basically, once we ascertain, for example, that they have been having this condition for a while and it's not improving, or the MRI scan warrants a surgery, then typically I would recommend that they fly in 1 or 2 days prior to their surgery date. And of course, this needs a little bit of time coordination. And they can come in and we can arrange for their admission on a specific day, on the day of their surgery. And typically, I'll recommend they stay in Singapore for at least 3 to 5 days, even though their hospital stay is only 1 day. That gives us an opportunity to make sure their pain control is okay before they fly back. Of course, Indonesia is quite close to Singapore, and I would be honest that many of my patients would, take that opportunity to run some errands in Singapore, and many of them would stay to the point of 2 weeks where we review their wound, remove the stitches, and then they can fly back to Indonesia. And subsequently, more important than our surgery, I think, is actually the post-operative rehabilitation, because while the surgery is a short and simple and straightforward surgery of 2 hours duration with one hospital's day stay, the rehab is an ongoing process. And typically for patients with rotator cuff surgery, I would strongly recommend they see a physiotherapist like yourself for at least 4 to 6 months to see that gradual improvement. So their pain relief will set in by 4 to 6 weeks, but their range of motion will regain at 3 to 4 months. their strength will regain at 4 to 6 months. So it's a graduated recovery, and they notice their improvement over a 6 months duration. And of course, during that 6 months duration, we can either review them virtually, or if they make any trip down to Singapore beyond that first 2 weeks, I think we can review them at the same time.
And what are the consequences if they delay the surgery, doctor?
Yeah, so it depends on what the tear looks like. So for some tears, I've seen them and I say, okay, look, you don't need any surgery, or this is something mild. I would say you see a physiotherapist, give it 6 months, and some of my patients improve and they never have to see me. But for the tears that are significant in size, especially if it's associated with a lot of symptoms, then I think those are the ones that we should try and repair them early, not urgently, but early. And the reason is because this symptomatic tears has been shown quite clearly in the medical literature. The tears that cause a lot of symptoms are typically the ones that retract and become bigger. And if we don't address this tear early, this tear can become bigger, and it's impossible for us then to repair this tear. And we may have to resort to other methods. For example, an open surgery, we may have to use a tendon graft from some a donor tendon to patch the defect in the tendon. So that's the consequence if we leave these tests unsupervised, especially the bigger ones.
Okay, this is very useful and very important information, doctor. Thank you so much for your time. Do you have anything else you'd like to add for our viewers?
No, I think I would only add that if they have any shoulder symptoms, it's always prudent to seek medical advice early and make sure we get the right diagnosis. Many a times the diagnosis is a benign one that can be easily treated without surgery. All right, but at least we know when we encounter the more sinister problems, we can nip the problem in the bud early.
Okay, thank you so much, doctor. For our
Thank you
viewers,
very much.
yes. For our viewers, if you are interested in speaking with Dr. Andy Wee, you can call at +65 912 58585 or WhatsApp at +65 962 86933 to schedule an appointment. You can visit their website at www.p-ortho.com for more details. If you're planning to get your surgery in Singapore and live in Jakarta, you can start your physiotherapy at Physioactive Singapore and continue your rehabilitation program in Physioactive Indonesia. On behalf of our entire team at Physioactive Indonesia, we want to thank you for tuning in, and we look forward to bringing you more top quality content from leading industry surgeons. Thank you, Dr. Andy Wee, and thank
Thank you very much.
Thank you.